to be there. So today we have three learned speakers who are going to talk about various aspects of medical termination of pregnancy, the law, the counseling, etc. And I'm looking forward to a fruitful program. I must thank Ajay and Foxy team for choosing Pune as one of the partners in this particular area. And I must thank my speakers. Professor Sushma Sharma, who's a professor and unit head at the Mymar Medical College, Dr. Richa Sharma, who's a national speaker, who currently heads the MTB committee of Foxy, and Dr. Uma Wankhede, who's the professor and head at Government Medical College, Baramati. So before we start with the presentation, may I invite Mr. Ajay Bharadwaj to say a few words. Ajay, you're muted. You need to unmute yourself.
Yeah, that's a usual practice which goes into play. Okay, it's an absolute pleasure to be here. Pune has always been, or rather Pune has always been close to my heart, given the several tips that we have been taking out there for several of our programs, especially with Sanjay, Dr. Sanjay Gupte, and several other team members who are present over there. And I cannot forget the sandwiches which are available on that special lane, or the bhakar vadi, which we cannot live without having them, and especially going and having the Durvankar Thali. You cannot leave Pune without having these three on your checkbox list. Now, coming to the seriousness of this program, it's in the 1970s, it used to be known as this unsafe abortion. In the 2000, the terminology changed to safe abortion. And now when we are in 2022, it's respectful abortion. So in the last 50 years, we have come a very long way. And India has the distinction of being amongst the top countries here who has a law in place for the last 50 years, whereas several countries continue to struggle with even a basic in terms of the service delivery for abortion care in their respective countries even today. So I think a huge, loud shout out goes to the government, the private practitioners and Foxy, who has made this possible and continues to deliver what is expected out of them for the benefit and the betterment of the women folk in our country. Having said that, even today, unsafe abortion is the third leading cause of maternal mortality in our country. Although the maternal mortality has gone down from some 526 some 15 years back to 103 today, the MMR, we still have a long way to go. And I'm sure with the abortion bit being taken care of with this new amendment which came out in September 2021, a lot is going to change. And as we say, the benefit is with the batsman, benefit of doubt. In this case also, the women is empowered, the adult woman who's 18 plus is empowered to take that particular decision. And with the support of all of us who are present over here with these learnings, we will be able to take this process forward. So today there are 4 sessions here which we'll be covering. The first session is going to talk about the MTP amendments itself, which is a very critical session, and talks about the various changes which are there, all for the good. The second presentation is going to be on the technology bit. Here I feel a lot has not changed. You are already using it and doing it in terms of the drug or the practices. Therefore, it is a reiteration of all that you're already doing. The third is the Saver module. We'll talk about in details when we come to that, but this module is also very critical because it addresses one of the very important aspects related to the stigma and discrimination related to the women. And many a times we as service providers, without knowing or without being in our subconscious, end up stigmatizing or at least questioning the very woman who has come for the services. So this is a very beautiful WHO program which you can do it online at your own time. And Sushma will be walking us through this entire thing. And the last bit is related to the pre-counseling and the post-counseling, because many times, given the time pressures that we have with our current practices, we may miss out on that. But if we are able to spend the 3 to 5 additional minutes on pre and post counseling, I think that will, rule out a lot of need for the requirement for abortions as we go forward. So with those little words, thank you very, very much for having me here. It's an absolute proud moment to represent, our beloved President Shanta Kumari, because of whom this entire project and this partnership with WHO has taken shape, and we have been able to do as many as about 8,000 OBGYNs from FOXY trained across the country. And now all of you are also possible. Thank you very much, Shanta Kumari, and thank you very much, Parag, for having me here. Over to you.
Thank you, Ajay, for those nice words. And it also means that your visit to Pune is long overdue. So we look forward to hosting you in Pune soon. Madhu, I think let's
Yes,
begin.
sir.
I think Umaya is still yet to join.
She's not
I
there,
can
yeah.
see her joining, and probably she's finding it a little difficult to join. So let's start with the second presentation, which is by Dr. Richa Sharma. And backend team, can you please start videos presentation of Dr. Richa Sharma?
A very good afternoon, everybody. Thank you, Pune Ops and Gynae Society, for giving me the opportunity. Thank you, Dr. Parag Ginivane, sir. So I will share my screen. So respectful abortion care, it is a joint FOXY and the WHO initiative. And I will be covering module 1, that is Medical Termination of Pregnancy Amendment 2021. So objective of this module is the evidence dissemination, and we will take a close look at what are the new laws, what are the changes in the rules. So unsafe abortion in India, it leads to maternal mortality, morbidity, and it also hampers the women and the girls' full participation. And it is found that 8% of the maternal deaths per year is because of abortion, and it is the third leading cause of maternal mortality. Nearly 2 out of 3 of the abortions performed are deemed to be unsafe, and nearly half of the pregnancy-related deaths are in the woman and the girl less than 24 years. So when is abortion considered to be safe? Now, WHO definition of safe abortion is that if the abortion is done by the appropriate methods and by the trained person. If both the criteria are present, it is called safe abortion. And if only one criteria is present, then it is called less safe. And if both the criteria are not present, it is called unsafe abortion. So Medical Termination of Pregnancy Amendment 2021, it clearly tells us about the safe and comprehensive care, which is
Sorry to interrupt you. I think there's a connectivity issue from the
salient
other
features
side.
of
My video is not projecting properly.
First is that the modification
No, we can see it,
requirement of the provider. So in the previous act, the requirement of the opinion of one provider for MTP up to 12 weeks was
Sriman,
needed.
can you just pause it, please?
And between 12 to 20 weeks, 2 RMP opinion was needed. Now, after...
Yeah, sorry. What is the issue? Because I'm able to see it. Maybe the issue could be the slow internet at your end.
Yes, probably. Even I can see it.
Yeah. Yeah, okay, Sriman, we can carry on then.
The amendment, now 1 RMP opinion is needed for MTP up to 20 weeks, and 2 RMP's opinion is needed for MTP between 20 to 24 weeks of gestation. So the potential outcome is that will be increase in number of facilities, especially in the public sector like PSCs, who are eligible for service provision till 20 weeks. Then next modification is for the vulnerable group of women. So in the previous act, the MTP was permitted only up to 20 weeks. And after 20 weeks, it was only when it is immediately necessary to save the life of pregnant women. But now, after amendment, the gestational upper limit is increased. Now it is up to 24 weeks for the special or the vulnerable category of the women. And after 24 weeks, it is only for the birth defects which are not compatible with life on medical board consensus. So the outcome will be, there will be an increased access for the vulnerable women to safe and legal abortion services defined by rules committee that includes violence victims, minors, among others. Then modification for birth defect and the congenital anomalies. Now, according to the previous act, the upper limit was only 20 weeks. And if there was any indication for termination like the birth defect, the patient had to go to the court. They have to file the petition, and then the court will order for a temporary board, and then board will take the decision. But now, after the amendment, upper gestational limit does not apply in the cases of pregnancies who have the substantial fetal abnormalities and diagnosed by a medical board. That means the upper limit is not there for the fetal congenital anomalies, but medical board will decide after 24 weeks. So the potential outcome will be there is increase in access to safe and legal abortion services who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies which are diagnosed late, and thus it will reduce the unsafe abortions and court cases. Then another is the modification which is related to marital status. Now, in the previous act, the condition of failure of contraceptive was applicable only for the married woman and her husband. But now, after the amendment, condition of failure of contraceptive will be extended for any woman or her partner. And the potential outcome will be there will be increased access to safe and legal abortion for any woman, irrespective of the marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. Now, this condition, it applies only up to till 20 weeks period of gestation. Now, next is the insertion of new clause for strengthening privacy. Now, in the previous act, the medical termination of pregnancy rule 2003, they had mentioned that the information should not be disclosed except under the authority of law. Now, with the amendment, the name and the other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person who is authorized by any law for the time being in force. So the potential outcome is that there will be increase in privacy and confidentiality of abortion seekers, increased demand, but need to be safeguard rights and dignity of the woman, and provide respectful bias-free services, including counseling and contraception. So this also the salient features of MTP Amendment 2021, it also prioritizes the confidentiality and the safety. That means the name and the other particular of any woman seeking abortion has to be kept confidential, except to a person who is authorized in any law for the time being in force. And the ground of failure of contraceptive has been extended to the woman and her partner till 20 weeks period of gestation. Rules under MTP Amendment 2021, it clearly defines a special or the vulnerable category of the women who are eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. And then the norms for the registered medical practitioner, RNPs, whose opinion is required for termination of pregnancy at different gestational age. And third, it also defines the power and the function of the medical board. So the special category of the women who are eligible for MTP between 20 to 24 weeks are the 7 categories of the women. Now, first is the survivors of the sexual assault, rape, or the incest. Second is the woman with pregnancy in humanitarian settings, disaster and or emergency situation as declared by the government. Third is the change of marital status during the ongoing pregnancy, as in if the woman has become widow or she is divorced. Next is a woman with physical disabilities, which means the major disabilities as per the criteria under the Disability Act. Then mentally ill women, that includes the mental retardation. Then minors. And then the last is the fetal malformation that has the substantial risk of being incompatible with life, or if the child was born, it would suffer from the physical or mental abnormalities, which will be seriously handicapped. So these are the 7 categories of the women who are entitled for MTP up to 24 weeks. Now the rules regarding the registered medical practitioner. Now the RMP that is defined in the old act as the MBBS doctor. So the MBBS practitioner should have assisted at least 25 cases of MTP, out of which 5 has been done by them independently. Or they have completed the 6 months of house surgency in obs and gynae. Or any medical practitioner who has the postgraduate degree or a diploma in obs and gynae, or a medical practitioner or MBBS doctor who has experience of at least 1 year in practice of obs and gynae. So these are the 4 categories of the registered medical practitioner who are entitled for doing the medical termination of pregnancy. And I have already told 1 RMP opinion is needed till 20 weeks, 2 RMP opinion is needed between 20 to 24 weeks, and then medical board opinion is needed after 24 weeks. Now, after the amendment of 2021, now another additional category of the provider has been added. That is, MBBS doctor can also do the medical termination of pregnancy up to 9 weeks by medical methods, provided they have experience in obs and gynae at any hospital for 3 months, or they have performed at least 10 cases of MTP by medical method under supervision of a registered medical practitioner in a hospital which is established or maintained, or a training institute which is approved for this purpose by the government. So to summarize, now till 9 weeks, who all can do the MTP? 1 is the MBBS doctor who has the experience at any hospital and has a 3 months in practice of obs and gynae, or if they have performed 10 cases of MTP by medical method under the supervision of any registered medical practitioner. Then another can be a practitioner who has assisted a RMP in performance of 25 cases of MTP, out of which 5 cases has been done by them independently. So this is for the MBBS RMP. Then another category is the registered medical practitioner who has a PG degree or a diploma in obs and gynae. They can do the MTP. Then MBBS registered medical practitioner who has a 6 months of house surgency in obs and gynae can do up to 9 weeks. And another is that a MBBS practitioner who has 1 year of practice in obs and gynae can also do the MTP till 9 weeks. Then till 12 weeks, who all can do the MTP is again a MBBS practitioner who has assisted RMP in performing 25 cases of MTP, out of which 5 has been done by them. Or they have a 6 months of house surgency in obs and gynae, or MBBS doctor having 1 year of experience in practice of obs and gynae. Then PG degree or a diploma in obs and gynae, they can do MTP at any period of gestation. Then between 12 to 20 weeks, who all can do MTP is again a practitioner who has a PG degree or a diploma in obs and gynae, they can do MTP. And then MBBS practitioner having 6 months of house surgency in obs and gynae, or 1 year of experience in obs and gynae, they can do the MTP between 12 to 20 weeks. Then 20 to 24 weeks, again, practitioner who has a PG degree or a diploma in obs and gynae can do the MTP. And also the MBBS practitioner who has a 6 months of house surgency in obs and gynae, or 1 year in practice of obs and gynae can do the MTP between 20 to 24 weeks. Then after 24 weeks, who all can do the MTP is the practitioner who is having a PG degree or a diploma in obs and gynae can do the MTP. And the second category is that MBBS doctor who has at least 1 year of practice of obs and gynae can do the MTP. But after 24 weeks, it is only after the approval of the medical board. And that also the board will decide depending upon if at particular period of gestation, this procedure will be safe to a particular woman. Then composition of the medical board. Now medical board will have 1 gynecologist, 1 pediatrician and 1 radiologist. Then the rules of the medical board. Now medical board, they can allow or they can deny the termination of pregnancy after 24 weeks of gestation. And this will only be after due consideration and ensuring that the procedure will be safe for the woman at that gestation age, and whether the fetal malformation has the substantial risk of it being incompatible with life, or if the child was born would suffer from the physical or a mental abnormalities leading to the serious handicap. Second power is that they can co-opt other specialists in the board and ask for the additional investigations if it is required for deciding on the termination of pregnancy. Now, the functions of the medical board are also to examine the woman and her reports, who would approach for medical termination of pregnancy. And then medical board has to give the opinion in the form, that is Form D, and they have to give the opinion within 3 days of receiving the request for medical termination of pregnancy. And they also have to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precaution along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. And we have to remember that FOXI has an important role to play in ensuring there are functional medical boards in every state, as it is stated in MTP Amendment 2021. So with this, I conclude. And now I request everybody to also give your feedback and do the post test so that the certificates can be mailed to you. In India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampoorn Bharat. Thank you for your patient hearing.
Yeah, Richa, it was indeed a nice presentation with very, very clear thoughts and messages. Just one quick question to you about, MTP center recognition. So what is the current status? Is it, see, right now there are MTP centers which are recognized up to 12 weeks, and there are most of them which are recognized up to 20 weeks. Now, is there any formality for the MTP centers that you need to do as a center head, so that instead of 20 weeks, you can perform MTP up to 24 weeks?
Yes, sir. Am I audible?
Yes, Richa.
So regarding the approval for the MTP center, now the current thing is that earlier we were getting the approval till 12 weeks or approval till 20 weeks. So the centers who have got the approval up to 20 weeks will automatically be approval up to 24 weeks. So what they have to do, they just have to contact their regional CMO and they have to get their forms, that is a certificate B, updated. So they don't have to reapply for the registration or anything, just automatically they will make a 22, 24. So that is the thing. And after 24 weeks, the MTP has to be done in the medical college only and by 2 registered medical practitioners.
Right.
So private setup, they are entitled for only up to 24 weeks.
Right. Is there any other question from the audience? You can either pose it in chat box or you can unmute yourself and then ask question directly. Now, Richa, now see, I am a private practitioner. I get a patient, say at around 21 weeks with gross fetal abnormalities, say maybe multiple anomalies which are not compatible with life. Then how do I go further?
Sir, if the patient is 21
so I'm
weeks,
talking only of not the methods, because that will come later. But then how do I tell this patient that yes, this can be done at the private hospital, or do I have to, because currently there are no medical boards existing. So the question in the mind of private practitioners is that how do we proceed further when we get such a patient?
Yes, sir.
We are unable to hear you, Richa.
Yeah, Richa, you are muted. You need to unmute and speak, please.
Okay. So you are asking about the termination of more than 24 weeks.
21 weeks.
So after
21.
24 weeks medical board, yes, but the medical boards, they are in the state of getting formulated. So
Right.
as in Delhi also, like most of the medical colleges, they have constituted the board, but the board is not yet notified. So if we are getting such patients beyond 24 weeks, so the procedure is still the old one. Okay, so at 21 weeks, sir, there's no problem. Between 20 to 24 weeks, there's absolutely no problem. You can terminate at your center, provided your center is approved one.
Okay, great.
And
Great. So this is one very important take-home message for all the audience, because those who are into private practice, they have to be very, very clear in their minds as far as this legal angle is concerned.
Some other workshops, one of the is related to a woman who is less than 18. What is the process that needs to be followed for termination of pregnancy? Richa, could you hear us?
Maybe you can repeat the question.
Yeah. A woman who is less than 18 wants to terminate her pregnancy. What are the guidelines?
yes, now I can hear. Can you please repeat the question?
Yeah.
Yes,
A woman who is less than 18 wants to terminate her pregnancy. What are the guidelines for it?
See, if the person is less than 18 years, so if she is a less than 18 and married or unmarried, she will fall under the act. Okay, so police has to be informed, MLC has to be made. Okay, and then we can go as per the protocol. We can use Mizo or suction evacuation or surgical, whatever. But less than 18 years, definitely we have to inform to the police. We have to take the receiving signatures and keep it so that you are medically safe later on.
Okay. And who will give the consent in
Am I
such a
audible?
case, Richa? Who will give the consent in such a case?
If she is less than 18 years, the guardian will give, parents can give, or if they are not there, then guardian can give. Guardian need not be the blood relative. Any person taking care of that woman can give the consent.
Okay, I think that helps. Thank you so much.
Okay.
Madhu, let's move on.
Thank you, Parag sir, for the opportunity. It
Thank
was
you
a
so much,
wonderful
Richa, for joining.
experience. Thank you so much.
Thanks again. We move on to our second talk, which will be given by Dr. Uma Wankhede, the professor.
Madhu, we can't hear you.
Sir, is it audible now?
Your voice is too low, madam.
Sir, audible now?
Yeah,
Yes,
yeah.
ma'am.
Yeah, thank you so much, Richa ma'am. It was indeed a very great and clear discussion. We now move on to our second speaker, Dr. Uma Wankhede ma'am, a professor at BJ Medical College, Pune, and a very, very important topic to be given by her about safe abortion. Uma ma'am, I hope you are there to connect with us. Give us your speech.
Uma is not seen.
She had logged in a while ago, but
Yeah, but I can't see her. Sushma, can we take yours till then?
Sure.
Yeah, we can move on to the next one. Yeah.
Madhu, in the meantime, please call Dr. Uma and request her to join back.
Sir, some network issues onto her side. She'll connect back, but she may take some time, sir.
Okay. So till then, we'll have Dr. Sushma's presentation.
Sure, sir. Sure, sir. Inviting Dr. Shushma Madam to please give us the speech onto the safe abortion values, evidence, and the rights which are being held The topic given over to you, ma'am, WHO Saver Toolkit. Dr.
Thank you
Sushma
so
Sharma,
much.
ma'am.
Thank you so much. At the outset, I would like to thank FOGSI and POGS. And we are indeed lucky to have a president like Shanta Kumari Madam, who takes such an important topic so much to heart. It's so close to, and I was so amazed to hear the figures given by Ajay sir at the beginning, that so many FOGSians have already been trained. Now coming to the module which I am going to be addressing, in this module we would like to see what do you mean by respectful abortion care. You know, throughout our training, as we have been residents of OBGY, we have all been focusing on how to go about the legality, how to do the technique properly, if there are complications, what to do, how to handle all that. And here now WHO and FOGSI are together talking about respectful abortion care. It's very much the need of the hour, and we'll take a look into what do you mean by respectful abortion care. And we will also go ahead and highlight how norms and stigma affect these services of part of the family planning and abortion care in this country. And we will also provide our audience with the WHO Saver resources for a respectful abortion care, which they at their own pace can look at and have access to also. Now we also, with that extremely detailed and informative session by Dr. Richa, that the law has changed. Now the MTP Act, after many years and lot of effort behind this, if I may really salute the people who have put in those efforts to bring up these changes. And now we need to disseminate all this into the actual provider, not just to provide information, but also to provide support to these huge group of people. And FOGSI has been, law is the largest provider based in this country for abortion care. Today, we are all privileged. Some of the better takeoffs from the COVID has been that we are all familiar and we realize the utility of online platform. So the entire country can have access to so many things. Now, medical methods of abortion have seen an increase in the uptake. They are early, they are safe, and we need to ensure that there is no conflation with the PC and PNDT Act of this country. And needless to reiterate that the patient's, not just her safety, but her respect and quality also matter more than ever. And we all have a role to play as their healthcare providers. So coming to the basic terminology, what does one mean? What is the respectful abortion care? So by this, we mean that, and this is borrowed from what WHO has recommended, and it refers to care that maintains the safety, the dignity, the confidentiality of the lady. At the same time, it ensures that she is free from harm and mistreatment, and she becomes empowered and is enabled to make an informed choice and is provided continuous support both during and after all types of abortion. So some of this, of course, we have been clearly providing. Probably it's time to address the smaller soft skill part, which sometimes we may not be paying a lot of attention to. And this is what this whole program is trying to also focus upon. And in simpler terms, so after that long definition, what do we mean? That we as a provider or as a patient, we treat and are treated equally with dignity, empathy, and compassion. And all this should come regardless of what race one belongs to, what is one's ethnicity, whether you're of either of the genders that are in existence today, irrespective of your socio-eco status or of your reproductive history, whether you have had previous abortions or you've had previous pregnancies or this is the first one. So if you ever feel that something is not right, we must all speak up. And as health professionals, like we were saying, again and again, we keep reinforcing that it is our duty to listen and to support. And communication is the key. We sometimes do fall short on that. And as a medical college teacher, it is heartening to see the NMC also taking small but sure and definitive steps towards inculcating this communication key right at the undergraduate. Now, what are the various norms and stigma associated with abortion care? Let's watch a small video on this.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
that probably was something in which all of us have perhaps been witness to or unfortunately been part of, in being part of certain types of preformed notions in our own head, or having seen people talk about it. So stigma and norms, what is the problem with them is that they perpetuate both disrespect and abuse. And it has officially been categorized into these various categories that you can see. So it can either be a physical abuse, or it can be verbal abuse, it can be sexual abuse, and it can be stigma and discrimination. Then there can be failure to meet professional standard of care itself. So even this is a type of disrespect to the patient as well as a kind of abuse to her. And what is the solution? And what is the right of the woman of this country? That she has a right to timely health care. And what kind of health care? The highest level of attainable health care. And there can be poor rapport between women and the actual care providers, that is us. And so the patient has the right to liberty, autonomy, self-determination, and she has absolute freedom from coercion. So there can be a disrespect in the form of the way our health system conditions and constraints which exist in our healthcare system. And every woman of this country has a freedom from harm and ill treatment. She has a right to this. She has a right to freedom from harm, and she has a right to be free from ill treatment. And she has a right to information, and she has a right to protection under these various laws, that is the MTP law, which we have all been listening to under POCSO. And she has a right to have an informed consent. She has a right to refuse, and she has a right to have respect for her choices and preferences with dignity and without affecting the quality of care that is being offered to her. Now, there have been found to be 12 domains of respectful abortion care. And let's have a look at what these are one by one, these 12 domains. She should be free from harm and mistreatment. Then maintaining privacy and confidentiality. Actually, it is very much the part of the MTP law itself. Preserving women's dignity. Now, this is something which is not laid down in the law, but this is very much a right of women who are seeking abortion care. Respecting her choices and engaging with these patients with effective communication skills. So we must be wary of how we talk to our patients who are seeking these kind of care. Then we must provide information and seek an informed consent. So again, let me tell people who may not be part of the teaching faculty set that again, we are today stressing more and more right at the undergraduate level about how to write an informed consent vis-a-vis just a consent, that we write something and we just ask the patient to sign there. So informed word is the operative word over here. And continuous access to support, so pre and post abortion care, which Uma ma'am will highlight for us. And we must enhance the quality of our physical environment and our resources, and we should provide equitable abortion care. And the providers who are providing this kind of services should be both motivated as well as competent. And we should provide contraceptive advice securely, and we should do good counseling along with just providing the healthcare. So it's time to strengthen all this implementation. So what are the important changes? We saw that one provider has more responsibility than just giving out services for abortion. So you have to give counseling for contraception, and you should provide referral and compassionate care. And we saw all the changes up to 20 weeks of gestation, only one RMP, up to 20 to 24 weeks. I think Richa ma'am has spoken very lucidly on this, and beyond 24 weeks for anomalies with the presence of a medical board for special cases. Here, there is a need for being sensitive and you have to be judgmental free and be time is important over here, because every single hour, minute, day will be causing that much of psychological trauma to the couple who is bearing that anomalous child. So we also need to prioritize the confidentiality and the safety of these patients. And rightly said over here, respect begets respect. So we should be very mindful of the socio-cultural aspects as per the class of patient or the region of the country in which we are providing these kind of cares. Now let's watch another small video on a on the guide to avoid stigmatizing language. All right. So WHO has formed a training module. It is known as the SAVOR toolkit. So I'll just bring it up for everybody. Okay. These are some special games. I'll share it. I'll also share these links in the chat box. So if you click on these are self-paced games and very simple to play. They're interesting. And with this, what happens is that it makes us look into our own biases, which may be having our own personal biases. So what I will do is that I will share this link in the chat box, so that people can probably pay. Okay, I'll have to exit this before I do. So I'll do that in a bit. So let me
before
go
that,
back.
there was a video actually.
Try this video. Right. So let's have a look at this one.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVOR, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVOR toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVOR has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So all of us need to be part of this, and I will share these links in the chat box. it. So once I'm done with the screen sharing, probably I can do that. I'll just, should I actually showcase this, or I'll just share it later on? The participants can follow that link and play those games and see exactly, it will give them a insight into their own thought process about the questions are posed like that. Okay, so from when we started from 1970 and we were shifting from unsafe abortions to the 2000s where the call was for safe abortions, and now in the 2020s it is time to talk about respectful abortion. So there are a few questions, very simple ones. If the audience would be alert and active and write the answers in the chat box. So this here comes the first question. According to the WHO, restricting access reduces the number of unsafe abortions. So is this true or is this false? You can type your answers in the chat box. If we restrict the number of restrict the access, that means we make it difficult for people to approach MTP centers. Will it reduce the number of unsafe abortions? What does the audience think? Okay, I have an answer. False. Okay. Anyone else would like to answer? Anyone thinks otherwise? Yes. So we have a very educated audience over here. Yes, the answer is that no, it will not, right? So just denying access is not a solution, but the answer is to providing appropriate methods and by trained persons. Here comes the next question. It is a clinical scenario based. So she's a 30-year-old woman who has been recently widowed and she wants to get an abortion at 22 weeks. So as her healthcare provider, is it our responsibility that we tell her to continue this pregnancy? So what would your answer be? Do you think it's your responsibility to tell her that she should continue this pregnancy? Okay, let me see the answer quickly. No. Assistant, of course, well versed with everything. Okay, so again, we'll go back to the recent amendments. So these kind of questions, scenario-based question, make us realize the new changes which have been brought towards this MTP Act. Okay, so let us all come together. So in India, we did know for the last 50 years, abortion has been made legal. So now let us all get together and make it both safe as well as respectful. So all the women of this country have access to legal, safe and respectful abortion care. And we'll move a step closer towards a Samarth Bharat.
Thank you, Sushma. Indeed, a lucid presentation. The videos were interesting, but the narration that you did was amazing. So it was wonderful to have you with us. Madhu, are there any questions for Dr. Sushma?
Sir, I think being a teacher and being a woman, she's actually put on the rights and responsibilities we hold. Very, very nice talk.
Yeah. I'll just share those links for the games in the chat box so people at their own pace.
Yeah, that will be wonderful. Thank you so much, Sushma. Uma, if you are facing challenges, then the backend team can, give the presentation and you can speak.
Yeah, I'm just ready now.
Okay, great.
I will share my screen.
Yes, please.
So we have our esteemed third speaker, Dr. Uma Wankhede, Professor and Head of GMC Baramati. She is an examiner for many of us and she has more than 50 scientific papers been published here to enlighten us about safe abortions. Uma ma'am, we welcome you to please give your presentation.
Parag, can you tell them to put the PPT because it's not playing?
Uma, stop sharing screen. Sriman, can you play the PPT?
Yes, sir.
The module on safe abortion.
Screen visible, sir?
Yeah. Uma, is that okay?
Yes, it's fine.
Yeah.
So, good afternoon, everyone. Sorry for the technical glitches. My topic for today is safe abortion, updates in technology. And this topic is jointly by FOXI and WHO initiative. Next slide, please. Well, the session today is according to the following 4 modules. First, we'll cover the existing guidelines which are present. Then the pre-abortion assessment that we shall do of the couple, mainly the woman. Then different medical methods of abortion and surgical methods of abortion. Next. So there are various WHO global guidelines on safe abortion. There is different books like Clinical Practice Handbook for Safe Abortion, Technical and Policy Guidance for Health Systems, Medical Management of Abortion, and Safe Abortion and Post-Abortion Counseling. So all the guidelines in today's talk has been gathered from these important WHO guidelines, and they are presented to you today. Next. So in 2012, the WHO has made a lot of work on safe abortion guidelines. On 2012, they had the technical and policy guidelines for health systems. In 2014, Clinical Practice Handbook of Safe Abortion. In 2015, health workers' role in providing safe abortion care and post-abortion contraception. In 2018, the guidelines about medical methods of contraception. And in 2019, guidelines on self-intervention for health. Well, all these guidelines were utilized and transferred to the National Forum. And now we have our own guidelines of safe abortion. Next. So now we know the historic change which has happened on 24th September 2021, which has already been highlighted by the previous speaker, that abortions has been extended up to 24 weeks. For abortions up to 20 weeks, only consent of 1 RMP is required, while for abortions up to 20 to 24 weeks, 2 consents are required. So this is a very important change in our system. And to mandate this change, it is essential that we provide safe abortion services. So now we shall see the different abortion services and how we can provide them to the consumer carefully. Next. So all the guidelines have 3 key areas in management. The first is the pre-abortion care. That is, the couple has come to us, they want an abortion. So what are the things we shall do to look after them before they actually go for the abortion? Then the different abortion methods, whether we would do a surgical method or a medical method. And the third is that even after the abortion, we don't just leave them, but there will be aftercare and follow-up, which is including very important post-abortion contraception and counseling. So most important is we help her in making a decision. If a woman chooses an abortion, she should be allowed to choose from among the different available methods that are appropriate for her. And the checkup of the patient follows a typical line, that is, first we take the proper history of the patient, then we do the medical examination of the patient, then we do the lab if required of the patient. And once we're sure that the patient is fine, then we go ahead with the abortion. So in the medical history, when the couple comes, we will ask them the age of the husband, the age of the wife, then how many weeks is she pregnant, then why she wants to undergo abortion, whether she has any significant past history, any personal history which is relevant to us, any drug allergies. Once we are sure that all is fine and she's a patient who wants an abortion, then we do a proper checkup, like we do the general examination, like considering the pulse, the blood pressure, the cardiovascular and respiratory system. We look for pallor, we look for icterus, we look for clubbing and edema. Then we have a good CBS and RS examination to rule out any abnormalities in the CBS and RS systems. And then with careful sterile technique, we would like to do a bimanual examination if we are sure that the uterus is not palpable abdominally, to know the size of the uterus. And once we are sure that, say the uterine size is 8 weeks or 6 weeks or 7 weeks or whatever it may, then we'll further go for the lab examination and then proceed for the abortion. Next. So this is about the pre-abortion and counseling. Next. So first I told you is very important, and most important is detailed history taking. Many things we come to know in the history, which we would, if we had not taken, we would have missed. For example, patient may say that she has allergy to certain drugs. Some patient once had just told us that she's got severe headache. And so we followed up the case and we came to know that she's got a brain tumor. So all these things, we are very vital in asking the history. And we should also know about her previous pregnancies, whether she had any mishaps, how many children she has, how many times she has done abortion before this, what contraception she's using. So all these things we should take history from the woman. I told you about the physical examination. A thorough general examination should be done. And then once we are sure that abdominally the uterus is not palpable, we should do a pelvic examination to see whether the size of the uterus is it normal size or enlarged, so that we know the gestation of pregnancy. Then about the lab investigation, commonly we are all doing hemoglobin of the patient to know the anemic status. We are doing the RH of the patient so that if she's RH negative, we could give her anti-D on the day of abortion. We are also doing urine of the patient to look for infections. We are doing HIV of the patient to see if she has a certain infection. And then depending upon the case, we could do more investigations. Suppose she has some particular problem, then our investigations will increase. Otherwise, basic investigation is just hemoglobin, urine, RH, and maybe an HIV testing. Once we are done through and we come to know that the woman is fit for the abortion, then we give her a detailed idea of the different methods of abortion. And we allow her to make the choice, her and her husband. And once they decide a particular method of abortion suits them, then we will counsel them further about the procedure so that they will be well informed before doing the procedure. Next. So gestational age is very important because by that we come to know whether it's a first trimester abortion or a second trimester abortion, whether it's abortion can be done by medical methods or surgical methods. So generally what we do is we palpate the abdomen, and here on this side you can see that they have said that up to 4 weeks the uterus is quite normal size, and at 24 weeks the uterus is up to the umbilicus, and if you go below that, 1/3 you make the abdomen between symphysis pubis and umbilicus, then the uterus is palpable at 12 weeks. It is just 4 centimeters above the symphysis at 16 weeks, 8 centimeters above at 20 weeks, and reaches the umbilicus at 30 weeks at 24 weeks. So by this we could know the size of the uterus from the abdomen. The limitations to dating of uterine size. Many times we may find that the uterus is too small or too large, etc. Then the reasons could be that there could be a malformation of the uterus like fibroid, etc., which is making the uterus appears large. There could be multiple gestations, which is making the uterus large. Uterus could be retroverted, so the size is not well felt. Patient could be obese, so that the uterine size. In H-mole pregnancy, the uterus than size. So we should be aware of all this, because patient may have told us that she's 7 weeks pregnant, 8 weeks pregnant, and here we are finding uterus which is say 12 weeks pregnant. So we should be aware that the uterus could be more than the dates of gestation. Sometimes may say that she's 8 weeks, 9 weeks, but the uterus is absolutely normal size. The reasons could be that the patient is just not pregnant, she just missed her periods. Or another important reason, especially in the rural setup, is patient is not sure of dates. She may tell us some date which she thinks is the last menstrual period and which could be wrong. And we are calculating the gestation age from that menstrual period. And sometimes it could be an extra-uterine pregnancy like an ectopic, etc., where the uterus would be normal in size. Or sometimes a pregnancy could be a missed abortion or a incomplete abortion where the size of the uterus will be smaller. The same case, the uterus is larger, I told you. The most important is, of course, inaccurate menstrual dating. Patient may say that she is 2 months, but actually she may be 3 months, something like that. or the patient may have multiple gestation where the uterus is larger in size because of the 2 feti. Patient could have a uterine malformation like fibroids, and patient could have H mode. So we should be aware of all this. So whenever in doubt, we think that why this patient is not, the uterus size is not corresponding to the dates, then we could go for sonography to confirm. And sonography will tell us most of the things. Like sonography will tell us if she's pregnant, what is the age of the pregnancy, whether there are associated fibroids, whether there are twins, whether there is a molar pregnancy, so or ectopic pregnancy. So in such cases, sonography will come to our help and help us to make a correct decision about the age of the pregnancy. Next. So it is said that routinely, no need of any tests for before an abortion. But we all know that we are performing the tests, that especially if we are not sure about the pregnancy, we are doing a UPT with the urine. We are taking a kit and taking the urine to confirm if she's pregnant or not. And if we feel she's pale, or it's a good idea to do hemoglobin of all patients, so that the hemoglobin is less than 8, then we could take adequate care before doing abortion. Otherwise, there could be complications to the abortion. I already told you, we must do the RH, because if she's negative and then 50 microgram of anti-D is given on the day of the abortion. And HIV testing should be done after pre-counseling, so that in case it's positive, we could take adequate care for the woman. And during the speculum examination, we would rule out any local infections like fungal infections, trichomonal infections, chlamydial infections, and accordingly give the treatment after the abortion. Otherwise, the infection may flare up and cause infection post-op. And if required, I told you that if the woman is having any particular history, like if she is having any history of liver disease or kidney disease or diabetes or heart disease, etc., then accordingly we will vary our labs to accommodate all those cases. In the end, it's written in bold that ultrasound is not necessary unless to diagnose of pregnancy, not sure or suspecting ectopic or missed. That's a fine statement, but generally most of us, I think, you all must be doing ultrasound, which is not bad to confirm the pregnancy and to be sure of the gestational age. But it's not a must according to the guidelines. If you have it, well and good, it will help you all the more. And if you don't have ultrasound, it will not matter if you're sure of your clinical findings. Next. Now, before the abortion actually you will have to ask the woman nicely, counsel her about why she's terminating the pregnancy. What is the reason? It should not be any trivial reason. Like sometimes a girl says that I have to do a job, so at present I'm not prepared. Someone will say that there are some economic problems, so we are not prepared. There is failure of contraception. Someone will say I already have a kid, so I don't want more at this stage. I mean, there are different reasons why the woman comes to us for abortion. So we must find out from her why she's thinking of terminating the pregnancy and her thoughts about terminating the pregnancy. Many women feel guilty, etc., that they are terminating their live baby. So we must reassure them that what they're doing is for the good of them, their family. And so they should not worry so much, and all will be well. You have to inform them that the earlier you do the abortion, the safer. So if you have a patient who is having a pregnancy of 7 weeks, another patient who's having a pregnancy of 12 weeks, naturally the patient who is 7 weeks will have a safer time with the abortion than the 12 weeks. So we have to counsel them that the earlier the abortion is done, it is more safe for the woman. Of course, a trained provider is going to do their abortion, like us, a doctor. So of course, the abortion we'll try our best to make it as safe as possible. We should tell her all the available methods of abortion so that she can choose whether she wants a medical method, or she wants a manual vacuum extraction, or she wants a surgical electrical extraction. So these are the methods which are available, and she and her husband can decide among themselves which to use. It should not be forced upon her. Then we have to tell her all the risks associated with the abortion method. Like suppose the woman says, "Ki chalo, humko medical method chahiye," then we have to tell her that she'll have to come 3 times to the doctor. Suppose she's planning to travel, etc. She cannot, because on the 15th day she'll have to come to us. And suppose she feels that there's no risk involved, just take the tablet and that's all. We'll have to tell her that there will be bleeding maybe for 2 weeks. She'll have to bear pain So we'll have to tell her all that. So that otherwise she'll think that it's a cakewalk taking the medical abortion. Someone has told a neighbor or a friend that just aap goli khao aur sab ho jayega. So it's not so simple. We'll have to tell her all the problems. Suppose she says that I want a surgical abortion. Then we'll have to tell her all the problems, that in a rare case, one in a million, say, then there could be a perforation. Of course, we'll try our best to avoid such problems, but there could be such things that tomorrow when such problem occurs, she should not be taken, that she has not been told all these things. So there are risks with each procedure. Generally, nothing happens. Commonly, nothing happens, but occasionally problems can happen. Also, we have to tell her that after this abortion, if she doesn't use family planning, then within 14 days, she can ovulate and get pregnant. So she has to be very careful. Otherwise, she'll have to have another abortion. So she has to be told that after this abortion, she must use some family planning methods so that when the time is right, she can choose and decide to have a baby. Otherwise, if she doesn't use methods, then she can get pregnant, unwanted baby. And again, she may have all the problems of abortion. We can also tell her that abortion, both medical and surgical, are safe. And within 6 hours of the abortion, she can resume all her normal activities. And even sexual intercourse is safe after, say, 48 hours. And she needn't worry. She can do her cooking, housework, etc. And she needn't have a caregiver with her with these small operations. And she should not worry. But they may ask, humko maa ko bulane ka kya, saas ko bulane ka kya, to help. So it's not required. If they are there, well and fine. But if it's not there, she can manage, because these are within 6 hours of the procedure. Patient can move about and do her routine activities. Once the patient decides, okay, I want to do abortion, we have to take an informed written consent. It's taken in Form C, that whether you're doing medical abortion or surgical abortion, it doesn't matter. You have to take the consent on the Form C, that I so-and-so give my consent for this procedure, and her sign. If she's not knowing English, then in the local language, the sign should be taken. If she's below 18, then the guardian sign should be taken. If she's not mentally normal, then the guardian sign should be taken. And also at the same time, patient should be asked about her decision to accept the post-abortion contraceptive. We can tell her that hamare paas bahut sare contraceptive methods hai, and we could give her an gather. We could tell her all about the contraception methods. Once she chooses the method, then we could go into detail and explain to her about the contraceptive methods and ask her for follow-up. There's a very important statement that many women, suddenly you talk to them, they are not willing for contraception. Their mother or mother-in-law has told them not to take contraception, it's not good, etc. They have their own personal experiences. They say, wo property bitaya to bleeding hota hai, wo sipil bitaya liya to vajan badh jata hai, etc., etc. So maybe she will not listen to us. But even then, we have to assure her that even if she's not willing for contraception, we will help her and do the abortion. Next. So now about the abortions, there is the first trimester abortion, which is commonly done and which is safe. And there are the second trimester abortions. Now, according to the amendment, only one doctor is required for the signing the consent form. So before 12 weeks, what is recommended we all use is mifepristone and misoprostol. Two drugs which we all use, and it's a very nice method of abortion with a very high success rate. Some people, they want to use only misoprostol. Fair enough, you can use only misoprostol. Results are slightly less than mifi with miso. And manual vacuum aspiration is a very good method of surgical abortion. We all have the MVA syringe, so we could do manual vacuum aspiration. And if we don't want the MVA syringe, we could use our suction machine and do the electrical suction. Now, less and less people are doing more than 12 weeks abortion. That is the second trimester abortion, because of various fears in their minds. So, but still it is our duty to offer abortion to all women above 12 weeks if they fit into the criteria of abortions. So here also we could give mifepristone and misoprostol 4-hourly till she gets good contractions. And once the contractions set in, then we could start oxytocin drip. Some people would like to give only misoprostol. They would give misoprostol vaginally 400 every 4 hours. What will happen because of misoprostol? The prostaglandins are released. There will be contractions, cervix will dilate, and patient will go in labor. And you could add an oxytocin drip and cause the abortion. Up to 16 weeks, those who are trained can do a procedure called as dilatation and evacuation. You need a large ovum forceps for this because fetal parts have to be evacuated. There's a lot of risk because you may leave a part behind or could cause perforation because the instruments are large size. But then this needs experience. So experienced hands, it's very safe, and up to 16 weeks, dilatation and evacuation. But what you should not do is dilatation and curettage, sharp curettage, because this would cause severe adhesions in the uterus and later Asherman syndrome, which is the intrauterine synecdoche. What is the Government of India recommendation for abortion? They say that up to 7 weeks, that is 49 days of abortion, you should give mifepristone 200 milligram orally on day 1, on day 0. And then after that, send her home after 48 hours. And then you take 4 tablets of misoprostol, that is 800 microgram. And either you could give it orally, that is take it with water. You could keep it in the vaginal fornix. You could keep it sublingual, that is below her tongue, or you could give it buccal. Buccal means you just keep the tablets beside the cheek and the gum for half an hour, and then later on she can swallow with water. But now the government has legalized abortion up to 9 weeks. So for 9 weeks abortion, which is larger, we have to give mifepristone 200 milligram orally, wait for 48 hours, and then give 4 tablets of misoprostol. Here we will not give oral because the efficacy is less. We will give 800 either vaginally or below tongue or below near the gums, that is buccal. So please remember, up to 7 weeks, which we all were doing, we could use meso either oral, vaginal, buccal or sublingual. But once she is more than 7 weeks, up to 9 weeks, to improve the efficacy of the abortion, meso should not be given orally, but 800 meso should be given vaginally, buccally or sublingually. Next. So this is the different methods of first trimester abortion. Medical methods, that is MMA, medical method of abortion, and surgical method is MVA, that is manual vacuum aspiration. EVA is electrical vacuum aspiration. So manual vacuum aspiration, you have a syringe which does the aspiration, and electric vacuum aspiration, you have a which does the aspiration. Next. So now let's see in detail about MIFI and meso. MIFI, we know, is an anti-progesterone. It inhibits the action of progesterone. So what we do at 0 day, on the first day when she comes, after we have checked her up, after counseling, everything, she's just up to 9 weeks. The criteria is she has to be up to 9 weeks, not more. Otherwise, the method is not so successful and it may cause a lot of bleeding. So once we have confirmed the patient is up to 9 weeks pregnant, then we give her 1 tablet of mifepristone. So mifepristone interferes with the continuation of pregnancy and the pregnancy gets separated from the wall of the uterus. Now, after 48 hours, she again comes back to us on the 3rd day. So that time what we'll do, we'll give her misoprostol or prostaglandin E1 analog. I already told you that up to 7 weeks, we could give oral, vaginal, buccal or sublingual. But above 7 weeks, up to 9 weeks, we don't give oral, but we'll give either vaginal, buccal or sublingual. What misoprostol does? Misoprostol further accelerates the process of abortion. It causes cervical softening, uterine contractions, and because of this, the products of conception are expelled. Next. Next. Yeah. So on the day 1, again, 200 milligram mifepristone is given orally. And if the patient is Rh negative and husband is Rh positive, anti-D should be given IM 50 microgram on day 0 itself, on the 1st day. So no need of some people try to give the anti-D on the 3rd day, 5th day, but it is best to give it on the 1st day so that before the bleeding starts, before the trophoblast separates, it will act and prevent the isoimmunization. Then on day 3, we give the misoprostol. So up to 7 weeks, you could give even simple 400 instead of 800 misoprostol. You could give it, I told you, sublingual, buccal, vaginal, orally. And later on, you have to give it only sublingual, buccal, vaginally, and only give 800. That is 4 tablets. It will do the job. Up to 7 weeks, 2 are also enough. It does very well. In addition to this, what we will give to the patient, because she'll be going home after 4 hours in the clinic. So once she's ready to go home, we give her analgesics because she'll have pain in abdomen for the next 4-5 days because of the uterine contractions. She will feel like vomiting because of the uterine contractions are so strong that she gets a feeling of vomiting. So we give her antiemetics, plus these medicines cause vomiting. And at the same time, if she agrees for contraception, we will give her contraception. That we'll see in the next lecture. And on 15th day, when she comes for follow-up, we will do a per vaginal examination to confirm that the uterus is empty, the os is closed, the uterine size has come to normal. We could do a sonography to confirm that the uterus is empty, complete. And now if the patient is ready, we will give her contraception. Next. So what are the routes? Oral tablets, the pills I told you, you take them in your mouth and drink them with water. So they are recommended only up to 7 weeks, 49 days of missed period. What are the side effects? Side effects are loose motions, nausea, fever, and chills. Misoprostol causes a little rigors, loose motion, and nausea. Now buccal, the pills are placed between the gums and cheek, that is just inside the cheek, and after half an hour, you can drink it with water. The chills and fever are more than with the vaginal route. Sublingual is you keep the tablets under the tongue for half an hour and then you drink the tablet. So here also fever, chills, diarrhea, vomiting are more compared to vaginal route. But the fastest onset of action and highest plasma concentration level is with sublingual because of the good blood supply under the tongue. Vaginal is the pills are placed in the vaginal fornices and the side effects are low. Minimum you have chills and rigors, vomiting, etc. But only thing is that the tablet may not completely dissolve and patient may notice some small fragments which may worry her. Nothing to worry, you have to explain to patient that nothing to worry. Counseling is very important. Next. So these they are showing here, they are showing that the tablets are kept buccal, that is in between the cheek and the gums for half an hour and then you drink it with water. And sublingual, you lift the tongue, keep the tablets, 4 tablets under the tongue, and then after half an hour, you can drink it. Here you can see 2 are kept on one side and 2 on other side, totally 800 microgram of misoprostol. Next.
Ma'am, I may take a minute. We have exceeded the time limitation of this talk. If we can close quickly, little.
No,
so
I will take this and take the next one in half an hour.
Yeah, sure.
Yeah. So the combination regime that you give mifepristol per, and if you want to give only misoprostol, you just give 800 microgram misoprostol, either buccal, per vaginal, oral, sublingual. Don't give mifepristol. Vaginal bleeding for 2 weeks is normal abortion, and sometimes almost 6 weeks. Next. So the provision for medical abortion should be available at primary care with referral systems so that if patient has any problem, she should know where to go to a higher setup. Suppose she starts bleeding or suppose she has infection, she should be having the facilities to go to a higher setup where all care will be given. And along with medical abortion, what we should do is counsel and test for sexually transmitted infections like chlamydia, HIV, syphilis. We should see whether the patient is suffering from domestic abuse. In private, we can ask her so that we can give her counseling and support. We should also give her any psychological support if needed. And if she has any other problem, we'll refer to the appropriate health specialist. Along with this, if she's anemic, we could give iron, we could give different pain medications, and most important, our emotional support. Next. So it is written that routine follow-up not necessary after an uncompleted medical abortion using miso, but we always call a follow-up. Better is to call after 14 days so that we know that the procedure is complete, and we can also offer the contraceptive services and address any medical concerns. But it is said that if you use only miso, then the success of the procedure is slightly less than when you use miso. So follow-up must be done so that if there's any retained bits or if it's incomplete or failed, then we could take necessary action. Next. So follow-up is When she comes back after 14 days, ask her whether she has any problem. Did she bleed a lot? Has she any pain, etc.? Does she have fever? Then review all the medical documents which were there with her. Ask her any problems she had during the procedure. Check her up, do a PV examination and a sonography, and see that the procedure is complete, and then provide contraceptive services. Next. Next. So the summary of medical method of abortion. Next. So day 1, we give mifepristone and offer NTD. Tell the woman to come after 2 days and record her experiences on the card. And we know that 3% women may completely expel with mifi only. She may tell, she may get the concept test, but still we have to give the meso on day 3. Change the slide, please. Next. Yeah, on day 3, we give meso, I told you. Observe for 4 hours in the facility. You can go give her analgesics when she goes home. And if she's willing, give her the contraception. The mean period of bleeding is about 2 weeks. She can have nausea, vomiting, diarrhea, headache, fever, dizziness. And if there's too much bleeding, then she must come back. And even if she's no bleeding, that means if the abortion has not occurred 24 hours after meso, then she must come back to us so that we can decide what to do next. And generally 75% women abort within 4 to 6 hours after meso. So this is a general rule. 25% may, some of them may abort at home, and some may not abort, 1%, and they may come back. And what to do on the 3rd day, we do PV, and then we give them the contraception, and then tell them that they have to use contraception and come back to us if there's any problem. And we all do to confirm that the procedure is complete, but it's not mandatory. Next. Madhu, please tell them to change the slides.
Okay,
next. Next. Side effects and complications. Yeah. So what most important side effect is pain. So for pain, if you counsel the woman that she's going to have pain, half the problem is solved. Then we give her some painkillers like ibuprofen. But if she has persistent pain and severe pain, then we must think of some rare possibilities like ectopic infection or incomplete pregnancy. Nausea, vomiting is slightly there, but that is reassurance will help, and we could give antiemetics. And slight diarrhea is there because of the misoprostol. That also will self-limiting. And if there's infection, she starts having fever and some bad discharge, then we'll have to examine her and start the antibiotics. Next. Please change her. Now, suppose the failure is there of medical method. She comes back and we realize that the pregnancy is growing. There's a live fetus. Then we have 2 options. Either we could use surgical method. Most women would prefer that. Or we could repeat the medical method, which many women may not accept. But suppose it's incomplete, like some products have passed out and some are inside. Then women will come to us with bleeding. So now if the bleeding is very mild, then we don't have to do anything. We have to just reassure her. But if the bleeding is heavy, then we could either repeat the misoprostol because some pieces may be inside, or we could offer her surgical method like MBA to remove the incomplete abortion. Next. Please change the slide. Yeah. So if the woman presents with heavy bleeding is defined as bleeding more than 2 pads in 1 hour for 2 hours. That means in 2 hours you change 4 pads. That means it's heavy bleeding. So you observe her. If it decreases, then you can go home after reassurance. But if she much, you do a PV. Many times the products are there in the cervix. You just remove them and the bleeding stops. You observe her and you can send her home. But if the bleeding, and you can do a sonography if the products are inside. Either you could do a manual vacuum aspiration, or you could give her misoprostol to complete the abortion. Next. And medical methods always comes under the MTP Act. So all forms have to be filled. C for consent form, I is for the RMP form. MBBS doctor with adequate experience can give the medical abortion. Monthly reporting form is form 2, which has to be given by the 5th to the district authorities. And form 3 is admission register, which we keep in our clinic or hospital. So all this has to be filled just like surgical abortion. Next. Next. Now we'll come to surgical methods. Next. So vacuum aspiration is the most liked by all doctors. It's the best method up to 12 weeks. And WHO recommends it as the safest method because all complications are minimum with vacuum aspiration. And routinely, we should not do a sharp curette in a pregnant uterus. Next. So the manual vacuum aspiration is a handheld aspirator and it can be transported from place to place. It has cannulae from 4 to 12, which can be attached to the nozzle according to the size of pregnancy. It does not need electricity, which is very good. You can use it in resource poor areas, and the cannula size corresponds to weeks of gestation. So IPAS cannula number 6 corresponds to pregnancy 6 weeks, 8 to 8 weeks. Accordingly, this is the IPAS plastic cannula, which is attached to this syringe at the end. Next. Next, otherwise you could use a proper suction machine. This is what we used previously. This is the electric suction machine. So the cannula is attached to the tubing, and the tubing, the cannula goes inside the uterus. And when you start the current, the electric suction will help to remove the product of conception. Next. Next, yeah. So cervical priming. Many times we see the cervix is very rigid and may not be easy to dilate. So there are different methods of priming. A simple could be you could give tablet of mifepristone 200 milligram 2 days in advance. Cervix will become nice and soft at the time of the procedure. Or you could insert 400 mesoprol sublingually 2 hours via the procedure, or put it vaginally 2 hours prior to the procedure. Or if you have laminar tent, you could just put it into the cervix 6 to 24 hours prior to the procedure. The laminar tent is hygroscopic, it absorbs water and swells and slowly dilates the cervix. So when you remove the laminar tent, cervix will be 2-3 centimeters and you could easily do the procedure. Next. So here pain is more important. It's quite a painful procedure. So there are 2 components of pain. Either you could use non-pharmacological methods, or more commonly we use pharmacological methods. Next. Next. So non-pharmacological method is to the woman, being next to her, explaining every step, performing the procedure very smoothly, and if the relative can be allowed in before the procedure starts, woman gets reassured, and woman may be told to breathe deeply and take a deep breath so that she feels less worried and anxious. More pain is because of the anxiety with the procedure. Next. In the slide, fast. So this is the pharmacological methods of pain. You could give general anesthesia is the best, but if you don't have it in your facility, then you could give diazepam orally 1 hour prior to procedure, or 2.5 milligram IV 20 minutes prior to procedure. The duration of diazepam lasts for 6 hours, and only the patient has little dizziness and chakkar, which will settle down after 6 hours. We all use lignocaine or local anesthesia to inject the cervix. So we use 1% local 10 ml, and we use a pericervical block, which is 2, 4, 8, 10, or paracervical block, just 3 and 9. You could inject it after aspiration, and the lignocaine will immobilize the local nerve plexus. The action lasts for about 1.5 hours, and there may be slight dizziness. And you could give women ibuprofen, 1 or 2 tablets 1 hour before the procedure. Ibuprofen also causes pain relief. It lasts for 6 hours, and if there is a uterine cramping because of the expulsion of the products, then ibuprofen is the best analgesic to be given to the patient. Next. Next. Please change the slide. Next, MBA steps. Next. So this is how you prepare the suction. You create the vacuum, you pull the piston back and create the vacuum. And then once you are given pain relief, ask woman to empty the bladder and tie up her legs. Then clean the cervix with betadine. And then you give the anesthesia with local anesthesia, pericervical block, and then you use the cannula itself to dilate the cervix, to dilate according to the weeks of gestation. And once you have dilated adequately, you put in the cannula up to the fundus. Next. Next slide. Please put the next slide. Yeah, so then you withdraw the cannula slightly below the fundus and rotate the cannula to anti-clockwise, clockwise. This will separate all the products of conception. And then once you have separated all the products, then you release the vacuum. Then all the products will come in the syringe. It's a 60 ml syringe and it can work up to 12 weeks of gestation. Next. Then you can check the products in water. They float in water, ensuring that they are poranic villi. If you are planning to do put an IUCD, you could put it at the same time. And then you process the instrument by soaking them in sodium hypochlorite along with your gloves so that HIV infection and all other infection is disinfected. Next. So post procedure, monitor, keep her for 4 hours, monitor for any problems. And once she's okay, send her home with some relative. Ensure that she has all the medications before leaving. All information should be cleared. And you can document whatever you did, including any side effects in the patient's card and give it to her on discharge. Next. Next. Aftercare, if the management of abortion complications, patients can have complications like incomplete. She may come with bleeding PV. There could be infection. She would have fever. She can have an ongoing pregnancy. She will have no bleeding, nothing, and she'll come back saying that all pregnancy symptoms are going on. Then we have to provide the contraception advice and offer contraception to her if she wishes. And if she has any other needs, sexual needs, reproductive needs, all that can be taken care of at the time of discharge. If only meso alone is used, no follow-up is recommended. Otherwise, we all call patients for follow-up so that we can know if they have any problems. Next. Next slide. So in the end, India has made historic process in improving access to safe abortion. Not much has changed. We are doing the same things in the last decade, but we have to be very safe and respectable. Abortion care is more important now. You have to treat the client very properly and make the experience worth having so that she'll tell her neighbors and friends about the experience. And every client has an opportunity to inform, educate, and equip with proper information on contraception and counseling. Next. So this is the end. Madhu, I'll just start immediately the next one. It will finish.
Yes, ma'am, you may. I'll just take one question which is being in the chat box. You can, ma'am, Dr. Kavita Jain has asked, is ultrasound mandatory for medical abortion? And should a copy of ultrasound record kept with the provider along with the consent forms being filled?
Yeah, ultrasound is not mandatory, but it's good to do. Most people will do an ultrasound so that they're sure that it's an intrauterine pregnancy, the gestational age, and it helps you in the deciding the method of abortion. It's not mandatory, but there's no rule like that.
Thank you, ma'am. Parag sir, can we? Yes,
yeah, let's move ahead with the next presentation.
Yeah. Yeah, this is the next module on pre and post abortion family planning counseling and leveraging technology, that is improving technology for helping the patient. Next slide, please. So what is counseling? Counseling is a structured interaction. Two people do counseling in which a person receives support and guidance from a trained person, that is us, in an environment that is conducive to open sharing of thoughts, feelings, and perceptions, so that she doesn't get scared and she is able to share her thoughts and experiences with us. That would be counseling. Next. Counseling is an integral part of abortion services. It's as important as the abortion itself, because counseling will help the woman to decide first whether she wants an abortion, second, which method she would like, whether she wants contraception, which contraception. All this she needs help from us. And whenever needed, the spouse also should be counseled. In fact, he should be counselled because he plays a vital role in decision making for the family. Next. So we are there to help the patient in all stages. We help the patient decide about termination, whether she wants to terminate or not. She's not very sure. In her mind, there are doubts. So she gets cleared whether she wants to terminate or not. Then once she decides, we help her to choose the method, whether she wants a medical method or a surgical method. Once she decides about a particular method, then we give her full information about that method so that she doesn't get scared and she has clearly in mind what to expect. And once she has decided on the procedure, we also counsel and help her to adopt a contraceptive which is suitable for her. Next. So during counseling, it should be private and confidential. So you should have a separate room. You should not do counseling in a busy OPD. Patient will feel very embarrassed. We should be very sensitive to the needs and non-judgmental. We should not force our ideas on the patient, but see what the patient wants. We should build up a rapport. So in the beginning, speak normal things and then come to the point so that the patient starts liking us and treats us like her friend or family. We must use simple language which she knows. Not use English if she is not proficient in English, but use Marathi if she is Marathi, and she should be allowed to ask all her doubts to us. And once she has made up her mind, then we go along with the physical examination to assess her for the procedure. Next. We have to tell her about the before abortion that important is she doesn't want this baby, right? But quick return of fertility occurs within 14 days. And if she doesn't take care, again she'll get pregnant and the same problem will be repeated. So this is the good time to talk to her about contraception. We should tell her that for her own health and for the health of the next baby, there should be minimum 6 months gap before she goes for next pregnancy. And there'll be better outcomes and a good mother and a good baby if she doesn't have pregnancies too often. And 90% of mortality can be reduced after abortion by ensuring contraception. By this, patient will not come again back for abortion. Next. The counseling should start at the first visit. Exception is if she's already in grief, she has lost a baby or there's some mishap, then we should not counsel at that time about abortion, about family planning, etc. But we can wait for some time. And what to counsel, I told you that she can get pregnant as soon as possible. She should use contraception. We should help her to choose the contraception. And once she chooses, we should tell her how the method is to be used. Say condom, say IUCD, say operation. So we must tell her a little bit about that. And if applicable, then we should talk to her about her high-risk behavior and how it will negatively impact her and the health of her fetus. So if the woman is not willing for contraception, she may say, "Abhi humko nahi chahiye, hum baad mein dekhenge, hum puchenge ghar pe, hamari saas ko puchenge." It's okay. Do not refuse any MTP. But after the procedure, again try to counsel her. And again, when she comes to follow up, try to counsel her. Maybe at that time she will be more amiable to your counseling. But don't refuse the MTP saying that "Abhi aap ye nahi use kar rahe, hum nahi karenge, aap jao ghar." That will be the wrong way of managing patient. Next. So for post-abortion comes contraception. We have to ensure that the abortion is complete. Uterus is empty. There are no products. There is no infection. There is no bleeding. There is no sepsis. There is no injury to any adjoining organs and no further pregnancy. Once all this is cleared, then only we can give her contraception. But generally post-abortion contraception may be an IUCD or a tubectomy or something. So everything should be clear before you start the contraception. Next. Post-procedure contraception, the woman has understood the precautions and care needed during post-abortion period. She should be counseled for contraception if she has previously not accepted, and we should tell her to continue using contraception once she decides to use and give her a proper method according to the couple. Next. Post-procedure also, privacy and confidentiality should be maintained. She may have any problems post-procedure like bleeding, fever. We must treat her, reassure her, and repeat the information about the post-procedure danger signs which she could have and for which she should come back to the doctor. Next. So post-abortion counseling, if she agrees, we must appreciate her, tell her that she's made a good decision. Immediately, we could start IUCD or injections, medroxyprogesterone, and oral pills. If she's taking, she could continue. We must ask her to follow up, and we must write everything in the card, and we must continue our rapport with the patient because she may have various problems for which she will need counseling and help. If she's not sure, then remove her anxiety. Ask her why she's not sure. They may be worried. They may be thinking that taking pills may make her fat, etc. So we must reassure her. And then we must ask the husband also for his views. And if still they disagree and they decide that they will use contraception later on, we must tell them about emergency contraception so that in case there's a mishap, then emergency contraception could be used. Next. I'll go in short about the different methods of contraception. The condom is the contraception used by the man as soon as sex is started. And it's a good method because there are no side effects, there's no cost, and it helps the man to take the responsibility of the family. And it also prevents against HIV and STIs. And it's easily available everywhere. So it's a good method. Only thing, it has a high failure rate. Next. The IUCD or the intrauterine contraceptive device is a very good method and it is very effective. So 380A can last as long as 10 years. MBBS doctors, nurses can be trained to insert IUCDs. PP IUCDs also can be done after the second trimester abortion. There's no interference with sexual activity and you can remove it, the patient immediately becomes pregnant. So when can you insert it? You can insert it immediately or up to 12 days after confirming a completed abortion using the surgical method. With MMA, you should insert it on the day 15 when she comes for follow-up and you're sure that the uterus is empty. In second trimester, you can insert immediately after the products are expelled or up to 14 days after the procedure is complete and there are no contraindications. So it's a very good method which should be used because it will give you a good spacing of 2 to 3 years and as long as 10 years, she can use the method. Next. COCs are there. COCs can be used immediately 7 days after abortion using surgical methods and as fast as 3 days after MMA. So, or within 15 days of the confirmation. And in second trimester, you can use immediately or up to 7 days. It's a very good method because it's very efficient. It regulates your menses. It can be provided by health workers who are taught how to use this. There's no interference with sex. It has a lot of protective effects on the female genital tract. Only problem is if the female is breastfeeding, then we can't use it because it will decrease the milk formation. Next. Now there are long-term injections, Antara, the medroxyprogesterone acetate, which can be given immediately up to 7 days after surgical abortion or even on day 3 of medical abortion. In second trimester, it can be used immediately or up to 7 days. It's a very highly effective, 100% almost. It's a confidential. It can be given by doctors, nurses after training. There's no interference with sex. There's no interference with breast milk, and it protects against a lot of genital tract infections. And it has no estrogenic side effects on the coagulation. Next. Female sterilization is a good method if the woman has completed her family. It can be performed after an abortion if there is no infection or bleeding, either along with the abortion or up to 7 days. You can do laparoscopy or mini lap, but with medical abortion, you should do it only after 1 menstrual cycle. You should not do it immediately. After second trimester, mini lap can be done immediately or up to 7 days after the abortion if there's no bleeding. But in second trimester, ideally laparoscopy sterilization should not be done. It's a permanent method of contraception, very effective, and there's no interference with sex, no interference on breastfeeding, and it should be widely counseled. Vasectomy is done on the male, but very few males decide to do vasectomy. It's a permanent method of contraception, very effective, and it has no long-term health risks, which the man might be thinking and anxious about. Next. So here they've just shown you a chart where you can see that COCs can be started on the 3rd day of the medical abortion. The injections can be given on the 3rd day of the medical abortion. Centroman can be given on the 3rd day of the medical abortion. IUCDs TL should ideally be done after the next menses. Next. For vacuum aspiration, COCs can be given immediately or up to 7 days. Injections can be given immediately or up to 7 days. Centroman can be given immediately or up to 7 days. IUCDs should be inserted immediately or after 15 days. TL can be done along with the sterilization. So all methods are safe with surgical abortion. Next. So this is a sexual and reproductive services given by teleconsultation. Now it's COVID era. Now it's luckily the COVID is going off, but the patients could not approach doctors. So here we could use methods of teleconsultation like Zoom or video calls and approach the patient. Next. So because of leveraging technology, that is improving technology to improve our services, we could have consultation over tele, Zoom or video call. We could counsel patients. Whatever we are doing face to face, we could do over the video or the phone. We could give guidance to them. We could give referrals to them, and even tele-linkage where we could ask them to go to different doctors if they have any problems. So technology has improved, and even in COVID era, patients can approach doctors through telemedicine. Next. So the government has started a nice website. I saw it yesterday. It's called Hamdo. It's a very good website where all details about family planning, contraception, abortion, everything is given and patient can ask questions. Even on social media, there is Ask Tanu. On YouTube, there are many platforms where they give information. Then there are helplines where patient can phone and ask about her problems. And education platforms of the WHO, Ministry of Health and Family Welfare and RCOG, where patient can approach and solve her problems. It will depend on the literacy of the patient. Next. The strengths of teleconsultation is in the COVID era when patients cannot go to doctors, you can approach the doctors through confidence and patients can ask their questions at ease. The weaknesses of this method is there is no face-to-face interaction. The doctor cannot demonstrate methods of. The opportunities are that it is private and comfortable in the home. It is cost saving. She doesn't have to travel. So, and the threats are that sometimes misdiagnosis can happen because patients are not directly examined by the doctors. Next. So the comprehensive abortion care, you confirm the diagnosis, you ask them for their contraceptive needs, you counsel them either directly or virtually through video conference or Zoom, and you follow them either by hybrid services or directly. One visit for misoprostol and for the mifimizo 3 visits. Next. So you decrease the inconvenience to the patient. Next. So the key messages are: realize the need of post-abortion family planning information, strive for 100% coverage, but it may not happen. Capitalize on the basket of contraception, use the gather method and apply in the post-abortion period. Like give them all the choices and allow them to make a choice and then explain to them the method as well as possible. Use technology as far as possible for abortion services. The concern is the costs of technology. The access may not be there for the people from the lower socioeconomic group. And adolescent reproductive health needs both online and offline consultations. Next. Thank you. Everyone should register, do their pre-test, post-test, and give back. I thank the RAC for giving the opportunity. I thank Dr. Parag for allowing us to speak on this session, and thank you all.
Thank you so much, ma'am. Do we have any questions from the audience, please? Ma'am, if you may allow, in this era of teleconsultation, I have a patient para 2 living 2 delivered by me 2 years back. Now she's in Kolkata 5 weeks, 2 days, and she's requesting me to give abortion tablets. This is because the family is...
Sir, I'm audible now?
Yes, yes.
Yeah. So, ma'am, in this era of COVID, the teleconsultation is at the height. I have a para 2 living 2 who delivered with me 2 years back. Now she's in her hometown, an IT sector people. She's 5 weeks, 2 days, and she's telling me the in-laws will insist her to keep this pregnancy. She wants abortion tablets. And she's requesting me to help her. Is it a practice of safe abortion? Should she see a doctor locally there, for which she is not prepared, being the comfort zone of her in Pune itself?
I think, Madhu, you could counsel her on teleconsultation, but I think she should see a local person that will check her up and assess, give her the medicine, and there will be a place where she could go to when she has complications.
Madhu, I'll just add something to what Dr. Uma has said. See, here, even if we are thinking of a medicated abortion, all the procedures have to be followed. So she has to have at least a checkup. She has to have the basic investigations. She has to sign the consent form, which are there in the MTP law. So you cannot do away with it. So it's absolutely something which we must avoid. So absolute no for such a consultation. You can do counseling, but no prescription of pills, because then it becomes illegal.
So, sir, I have screened her doing her routine test and asking her to go to a local person itself.
Yeah.
Yes.
Dr. Sushma wants to say something.
Yeah, ma'am, please.
Yeah, the very prerequisites of offering these pills is that the prescribing doctor should ensure that your patient has access to emergency surgical evacuation procedures. So it's against the prerequisites. It's very clearly laid down. So there's no question of it.
Sure, ma'am. Thank you. Anybody else with some upcoming questions and some interesting doubts to be cleared? So like Uma ma'am said, doing some investigations is a prerequisite. Lately, I saw a patient, very close friend, who took the pills by herself, landed up to my OPD with hemoglobin 5. The next day morning, she had giddiness at her home, hemoglobin was 3, and she was admitted in the ICU. So absolutely bad experience, even with the close by relatives. I think we need to put this awareness and spread this like our president sir is doing. And I think it is a noble cause to actually let the people know what is the importance of taking an anti-D. Many girls are not aware of taking anti-D. They will ask you, kya jarurat hai? Baby ka blood group is yet not. I think this needs to be enlightened and circulated in as many people as we can.
Yeah.
All right. So thank you, Dr. Uma, Dr. Sushma, and Dr. Richa. All the presentations were wonderful, and it gave us a fresh insight of what is new in medical termination of pregnancy. We have to understand that there is a law which governs medical termination of pregnancy, and we as clinicians, as healthcare providers for women, must follow whatever is written in the law, because if we don't, then it becomes illegal abortion, and I think that is something which we certainly would not like to have. So thank you, the team MITI and Avni Foundation, who are the partners. And before we close, there's a link shared about for the post-test and feedback. So if we need to complete it in order to receive a certificate. So thank you all, and let's go ahead and I think let's fill up. Yes, please.
Sorry to interrupt you, sir. I just posted a feedback link in chat box, sir.
Yeah.
Ask every participant to click on the link, and you will be redirected to post-session feedback, sir. Answer all the questions, and we'll issue the certificate as early as.
Sure. Thank you, Sriman. So please complete the feedback form and post-test and receive your certificate. Thank you very much.
Thank you.
Thank you to all the speakers for giving their precious time of hour at this peak hour of our work schedule, making us clear with the abortion protocols and the women ethics to be followed. Special thanks to Mr. Ajay Bhardwaj for doing the noble cause all around, and our President Sir Parag Biniwale to give us this opportunity and discuss it to a major platform.
Thank you so much. Been a pleasure.
Yeah. Thanks.
Thanks, ma'am.
Yeah. Okay. Bye-bye. And we'll meet next week on the 27th. We'll have the first outreach program in the area of Wakad. So whosoever can participate are most welcome. And not to forget our next big event, that is UIRT, which is scheduled on the 21st and 22nd of May in the city of Pune. So hope to see you all soon. Thank you very much.
Thank you.
Thanks, everyone.
Okay.
Bye.
Yeah. Thanks, Madhu.
Thank you, sir.